Assalamu alaikum. So this is how to interpret a CTG or cardiotocogram or non-stress testing. In general, everybody as a medical student, as a gynecologist, as an intern, resident, consultant, everybody should know how to interpret a CTG, because if you're doing an obstetrical practice, you have to know what does it mean or how to interpret it. So first of all, we have in any CTG, there is what you call it a data informations, where you have a sticker here stating the patient's name and medical record number. And then here we have what you call it lot number, or what you call it the serial number. And this number never exists twice. Meaning if there is any medical legal case, investigations, whatever, they cannot replace a serial number of a CTG by another from anywhere in the world. So they cannot have it twice, that's why. And then if you're looking here, we have the vertical axis and we have the horizontal axis. And talking about the vertical axis, there is always numbers like 60, 80, 100, 120, 180, whatever. So this is basically heart rate. And then in the horizontal axis, we have time as seconds. So this is time as seconds, and this is horizontal, the axis, which is the heartbeat. And then when we talk about the CTG, we have to know that there is a maternal part which represents the contractions, and then we have the fetal part which represent the fetal heart rate. So talking about the component or how to interpret the CTG, we have to comment first of all about the baseline fetal heart rate. So the baseline, the normal is 120 to 160, and as you can see here, there is what you call it beat to beat variability. So if you are taking the majority of the line, this is between 120 and 140. So we can say the fetal heart rate, the baseline is around 130, and then there is what you call it beat to beat variability. So what is beat to beat variability? This is the difference between each and every beat and the other one, and it should be at least 5. So the difference in a healthy baby between beat to beat or beat to beat variability should be 5, and you should not have a flat line. Yani here, if we consider this one as fetal heart, this is not a fetal heart, but assuming if we are talking about fetal heart, this one should be flat, and this is not reassuring, but this is uterine, as I said, but I mean just as an example. So this is a good beat to beat variability. And then we're gonna need to talk about acceleration. So fetal heart acceleration, to consider it a real acceleration, it should be at least 15 beats acceleration for 15 seconds. As I said before, vertical is number of beats, horizontal is time, seconds. So this is an acceptable acceleration because we have more than 15 for more than 15 beats for more than 15 seconds. So this is acceleration, and this is acceleration. When you do routine CTG, not in labor, you should wait for at least 20 minutes, and you should have 2 accelerations in 20 minutes to consider it reactive CTG. To consider it reactive CTG, you should have 2 accelerations of 15 by 15 in 20 minutes. Then you call it reactive CTG. If you don't see the accelerations, but you see a good beat to beat variability, you can consider it equivocal. يعني لا هو reassuring ولا non-reassuring, it's equivocal. What we know that the fetal movement usually associated with fetal heart acceleration. Usually they give a mother a button where they can press. This is a movement, and this is a movement, and this is a movement. Meaning if the mom, she felt the baby is moving, she gonna press on the button, and as you can see here, as a reaction, the healthy baby should react by accelerating the fetal heart after movement, and exactly this is what's happening here. So this is basically baseline beat to beat variability, and then we have what you call it the accelerations. There is a short-term beat to beat variability, and there is a long-term beat to beat variability. If you're looking here, the whole strip is like a wave, like a big wave. So the long big wave is the long-term beat to beat variability. However, the short-term beat to beat variability is what we are describing here. And then we have what you call it accelerations. but now we're gonna need to know what is decelerations. And in general, we have three types of decelerations, and the types of decelerations are correlated to the uterine contractions. We have early, late, and variable decelerations. So as I said, you correlated with uterine contractility. As we can see here, this is uterine contractions, uterine contraction. This is like there are maybe 4 uterine contractions. And in general, when you talk about early decelerations, this is where the deceleration starts with the contraction and ends with the contraction, and usually it represents what you call it fetal head compression. So head compression will lead to an early deceleration, which is not worrying. You don't worry about early deceleration because this is physiological, which increases the parasympathetic. What we can tell if this is early or late, so you can use your paper here, you can put it this way, and as you can see, it's like a mirror image. The contraction starts with the decelerations, and then once the contraction recovered, the deceleration starts to recover. Okay, so this is considered early deceleration. If you're going to check it again, you can see here the contraction starts, which is in the bottom here. Contraction starts, and then on the other hand, when the contraction recovers, the deceleration recovers. So this is considered early deceleration. The baseline in this strip, you can see the fetal heart is between 120 and 150, so this is roughly around 130 as a baseline. There is slightly decreased beat-to-beat variability. If you can see, it's not as zigzag as before in the previous case. The second type of decelerations is called variable deceleration, and you can remember it by variable V. It's a V shape. It's not like the one before. That was like a U shape, but this is a V shape which looks like a V, and usually it is associated with the contractions or sometimes irrelevant to the contractions, and it represent or reflect cord compression. You see it in a patient sometimes with oligohydramnios. In a healthy babies with oligo or after rupture of membrane, you can see it. So this is a good beat-to-beat variability, and you can see the decelerations are roughly V shape, and sometimes it has nothing to do with the contraction. So variable decelerations is related to cord compression. This is another example of variable decelerations where it looks like a V shape, and mostly it has nothing probably to do with the contraction itself. This is a real deceleration, so forget about this one, but I'm talking about this deceleration is a V shape which has nothing to do maybe with the contractions. This one is correlated with the contraction, this one also, but in general we consider it as cord compression, which is not very worrying. The third type of deceleration, this is the serious type, which is called late decelerations. As you can see here, this is a late deceleration where you have a contraction started here. However, the contraction started, and then after some times the baby decelerated, you see, so this is the contraction, so the deceleration didn't happen at the same time, and then there is a recovery of the deceleration, as you can see here, recovery of the contraction, I mean, but there is no recovery of the deceleration. So it is after, and again there is a contraction started here, the contraction started here, and what happened is the baby maintained the blood heart rate, I mean, for some times, and then started to decelerate, and here exactly the same, the contraction recovered, and then after some times the deceleration recovered. So this is late deceleration, which represent, as you can see, the timing is different here, and it's not mirror image, and this is considered serious, and usually it reflects uteroplacental insufficiency, like an IUGR, for example, or hypertensive disease of pregnancy. This is another good example of late decelerations. As you can see, fetal heart decelerated from 140 as a baseline, and then the contraction started. Baby did well for a few seconds, and then the baby decelerated, the contraction recovered, and then after some times the fetal heart recovered. As I said before, it's uteroplacental insufficiency. To remember it, what is the mechanism? We know that if there is a baby who's already compromised with abnormal placentation or abnormal uteroplacental perfusion, you know that during the contractions, or what we call it uterine systole, there is no perfusion. This is normal. There is no perfusion during the contraction. And what happens is, if the baby has a low oxygenation already, baby is a sick baby, during the contraction, the uteroplacental perfusion will stop, so the baby got some oxygenation because he's not a healthy baby. The contractions will be, let's say, for 10 seconds or 15 seconds. So the oxygenation of the baby will be enough for, let's say, 2-3 seconds, and then the baby will start decelerating. And then what happens after the recovery of the contraction? The baby start to ventilate again through the uteroplacental perfusion, and there will be some more oxygenation. And what happens, it takes some time till the baby got some oxygenation, and then start to accelerate again. So this is reflecting uteroplacental insufficiency, and this is type which is a serious type. This is an example of variable decelerations. As I said before, it's a V shape, and as you can see, it looks like a V, and usually it reflects cord compression. To summarize what we just explained, you have to know that there is main components of the CTG. First of all, you have the data informations where there is a sticker with the patient's name and medical record number. You have to make sure that there is a serial number which never exists twice. And then we have maternal part, contractions, and we have fetal part, which is fetal part, which is a CTG, which is the the fetal heart rate. And then we have the vertical components, and then we have the horizontal. The vertical is a fetal heart rate, and then a components in the horizontal aspect, which is the time. And then remember that we have accelerations, which is 15 by 15, 15 as a time, seconds, and 15 as a heartbeat, as elevation. And then we have two accelerations in 20 minutes to consider it reactive CTG. And then we have decelerations. We have three types. We have variable decelerations, cord compression, and we have the early deceleration, which is head compression, and then we have the late decelerations, which is uteroplacental insufficiency. Remember also, you need to comment on the beat-to-beat variability, which is a very strong indicator of fetal well-being. So beat-to-beat variability, it should be at least 5 beats between the beats and the other one. And there is baseline fetal heart, which is normally between 120 to 160. Regarding the uterine part, we know that the uterine contractility, there is a unit called, so the vimtometer is VM2 meter. It's a unit used to calculate the uterine contractility. It's probably too advanced for you, but you have to know it, maybe in case if anybody asks you from the external examiners. And the vimtometer is the number of millimeters. You calculate here the number of millimeters as an amplitude for each contraction, and you sum it up in 10 minutes. So let's say if this is like 10 minutes between here and here, you sum up the numbers of millimeters of the contractions, and then you add it up. If it's 200, it's considered progressive femtometer, which is effective labor, which may cause cervical dilatation and progression of labor. Okay, so the femtometer is the lumps or the sum of the number of millimeters as an amplitude of all the contractions in 10 minutes, and that represent the uterine contractility. But as I said, if you want to know the number, what is the magic number for effective labor, if it's more than 200, it's less than that, you may have to use Cinto for augmentation or for stimulation. Thank you. So this is Dr. Gari. You can always review my page, and there are lots of scientific materials related to obstetrics and gynecology and gynecologic oncology.